Have we let everybody in?
Just yeah.
Are we ready to go?
Yeah.
Yeah. Fantastic. Right. Welcome, everyone. We'll kick the webinar off shortly. I'm just going to do a brief introduction, just chat through the presenters and a bit of housekeeping as well. So welcome to today's webinar, which is going to look at raising awareness of alcohol during pregnancy and fetal alcohol spectrum disorder. We'll shortly hear from Laura Caldicott, who's kindly recorded her slides for us because she has to be somewhere else today, and she'll chat through alcohol throughout pregnancy and FASD from a midwifery perspective. And then we've kind of got Helen Christmas, who's a consultant in public health. We'll chat through some of the data that we have around alcohol in pregnancy and FASD. And then Maria Catterick, who is going to talk about the work of the National FASD organisation and the resources that they have at their disposal. And then finally, we've got Charlotte and Alice, who are going to talk about FASD from a parent's perspective and an adult's perspective. So really jam-packed webinar with lots of information and some fantastic speakers today. If there are any questions, could I ask that you pop them in the chat function and also put your email address along with it. And if we don't have time at the end to answer them, we can come back to you with a response. And we've also put a brief evaluation form at the end of the slide decks. We'll share the presentation after the webinar's finished, the recording. There is a QR code and a link for the evaluation. If we could ask that you complete that, that would be much appreciated. It shouldn't take any more than a few minutes. It's very brief and it just captures the feedback from today. And then lastly, if you haven't already, just to ask if you could mute your microphones, and that'd be really good for our speakers. Thanks everyone for attending, and I hope you'll find the session really useful. So we'll start the webinar now.
Hi everyone, I'm Laura and I work for the Humber and North Yorkshire LM&S, and I work as their prevention lead for weight management and alcohol prevention during pregnancy. I also work as a midwife at NLAG. I've been invited here today to talk to you about alcohol during pregnancy and also about fetal alcohol spectrum disorder, which is also known as FASD. The current advice by the UK Chief Medical Officer is that no alcohol should be consumed during pregnancy or if an individual is trying to conceive. Alcohol passes over the placenta and into the fetal bloodstream, and the fetal liver is very immature and cannot process alcohol properly. Therefore, alcohol can affect the fetal development. Alcohol consumption during pregnancy can also influence whether a baby has a low birth weight. It puts the individual at high risk of experiencing a miscarriage and also at high risk of experiencing premature labour and birth, and then at higher risk that the baby will have FASD. It is important to emphasise that any amount of alcohol consumed during pregnancy can cause these adverse events. So what is the healthcare professional's role in relation to alcohol during pregnancy? We should ensure that we make every single contact count with individuals, whether that be at home, clinic or in a hospital setting. We should ask about their alcohol habits regularly and ensure that they know what the current guidance is. We should offer continuity of care where possible. Evidence shows this is the most effective way to form relationships, and that the more often we see an individual, the more likely that they are to disclose alcohol habits to us, and therefore we can act appropriately. Individuals may not want to disclose this to a stranger, but they would be more likely to disclose this to someone that they have seen before and therefore trust. All pregnant individuals should be educated on the effects of alcohol during pregnancy and FASD. We know that not all individuals who are drinking alcohol will disclose this to us, and therefore we don't know who's drinking and who's not drinking during pregnancy. Therefore, it's so important that we educate absolutely everybody. As healthcare professionals, we should use motivational interviewing techniques when having sensitive conversations. This allows us to accurately identify where an individual is on the behaviour change ladder and have a more effective conversation surrounding alcohol. This can also assist their behaviour change positively. We should refer individuals to appropriate support services and maternity services where necessary. Fetal Alcohol Syndrome Disorder, also known as FASD, is a disorder which encompasses physical, cognitive and behavioural issues which all stem from the maternal alcohol consumption during their pregnancy. These issues may or may not include movement issues, balance issues, problems with vision and hearing. The individual may struggle with learning issues such as thinking, concentration and memory. They may struggle with managing their emotions and developing social skills. They may have hyperactivity disorders and also issues with impulse control. They may struggle with communication and other problems with speech. And they may also have issues with joints, muscles, bones and some organs such as the kidneys and the heart. The picture on this slide represents some of the facial characteristics of an individual with FASD. Some individuals may have a lot of these facial characteristics and some individuals may have very little or none at all. We need to be aware of this when we are talking about FASD and make sure that we are aware that every individual case is absolutely different. Thank you so much for listening. I do apologise that I've not been there this morning. I'm currently hopefully asleep after a night shift on labour ward last night. But again, thank you and thank you for coming to the webinar and I hope you enjoy the rest of the speakers.
Thanks, Laura, who hopefully is catching up on some sleep. I'm going to hand over to Helen Christmas now, mentioned public health consultant for Hull City Council, is going to chat through some of the data that we have around alcohol prevalence and FASD as well.
Brilliant, thank you, Jason, and morning, everybody. I have a feeling that I drew the short straw with this presentation because the short way of talking about it is we don't have a lot of data. And as Jason shared the slides with me, and I've been ringing him up all week going, are you sure we don't know about this? Are you sure we can't get more up-to-date data? And it's really shocked me how poor our understanding of prevalence is and how under-researched this is as a subject. So I will, if you would move on to the next slide, I will do my absolute best. But the reason there isn't much data here is because actually we have a real lack of data around this subject. So we do know a little bit around drinking habits during pregnancy, and we know that an estimated 41% of pregnant women drink during their pregnancy in this country, and we are quite high compared to other countries on that. But we also know that patterns of alcohol use and consumption change over time. And so all the things that we're talking about today are generally from quite dated data. So that may have changed, although the facts about FASD and our desire to prevent it won't change. So quite a high drinking culture in this country, including in women who are of childbearing age and through pregnancy. It's really difficult to separate out the impact of drinking during pregnancy because there's so many other things that can impact, diet being one of them. And as I've said, this is a really under-researched area and we don't know whether there is a safe level of drinking in pregnancy. We don't know at what point the harm occurs, and it can be different for every woman. So the guidance is, it's safety netting guidance is that the safest approach is not to drink at all during pregnancy, or if you're planning a pregnancy. And that can be really difficult guidance. That is often challenged by people who say, well, actually, you don't know that this and you don't know that. But the safest approach, because we don't know some of the exact mechanisms, the exact timings of the harm that can be caused, we don't know why a smaller amount in some women can cause more harm than a larger amount in others, the safest approach is not to drink at all. And those guidelines have changed over time, so people may not always be up to date with them. Grandparents may not know, or prospective grandparents may not know that this is different. And you will often get, it's a really common thing for people to say, well, I drank during my pregnancy and my child turned out fine. And that on an individual level, it's fantastic news, but on a population level, we know how much harm can be caused, and that's why that safety advice is that it's best not to drink at all. Do you want to move on to the next one, Jason, please? So prevalence. We know that heavy drinking during pregnancy can lead to fetal alcohol spectrum disorder. As I've said, it's really not clear in detail. We know we suspect, or research suggests, that some times during pregnancy are more risky than others, but there's not enough evidence to be able to pinpoint those sensibly in population level advice. We know we're saying heavy drinking here. Guidelines in the UK, obviously for pregnant women, are not to drink at all. Low risk drinking or drinking that's not likely to cause harm is said to be up to 14 units a week for men and women now. 15 to 34 is considered hazardous units a week, and 35 plus units a week is termed as harmful. And there isn't a specific number put on this in terms of pregnancy, but heavy drinking. In the past, I think we've used the term binge drinking, which tends to refer to really short intervals of very heavy drinking, but we know that that not binge but ongoing drinking can also cause that harm. In terms of prevalence, then, access to diagnosis is really patchy. It's not well covered in training for clinicians. There's a lack of awareness. There is no one way of diagnosing FASD. There's what you call a gold standard number of indicators or set of indicators that are used, but there's no one test. So and it's also it's associated with lots of other conditions and can be similar to other conditions with different causes. So it's a really difficult one to diagnose, and the numbers are very low of actual diagnoses. And again, this is another one saying, have we really got nothing since 2014-15? But I think that shows you just how under researched this area is. 276 diagnoses in 1 year in England, and that's highly likely to be a real underestimate because of that difficulty in getting diagnoses. Shall we move on to the next one? The best study that we have was carried out by Salford University just before the pandemic, and my understanding is that it got cut short by the pandemic. So it is a really small study that was only carried out in 3 schools in Manchester. So it's fantastic that we have this, but it's really important to emphasise that this may not be translatable across the whole population in the UK. But what they did was they looked at 8 and 9-year-olds in these 3 schools in Greater Manchester. They screened them on a broad screening tool, and those that came up as potentially meeting the criteria for having FASD were then invited to a more detailed investigation. And of those 3 of those 8 and 9-year-olds who took part in those 3 schools, they decided that 1.8% of those children met the clinical criteria, and 3.6% possibly met them. So a bit of a grey area around there, which just emphasises how difficult it is to have a definitive diagnosis. That is clearly an awful lot higher than those NHS numbers would suggest, and most of those children had not, or none of them had been diagnosed with FASD, and most of them had not previously had any diagnosis of a developmental condition. So what that means is we don't know how many people have got FASD, and it also means that those children and adults who do are not accessing the support that would help them, and are not eligible for that support because it's not known about. It's a figure there that it equates to 1.2, 1.4 million in the UK. I think that's a bit shaky, actually, for such a small study, and actually it wasn't clear either what age group that relates to. But even if we were to say primary school, primary age children, that's an awful lot of undiagnosed need. Do we go to the next slide, please? So, as we've said, nice guidance, no known safe level of consumption, but this is really, really difficult area. Most women don't well, nobody knows they're pregnant straight away, do they? But about half of pregnancies are unplanned. Many people will take a fair length of time to conceive and will carry on their normal day-to-day life while they're hoping to get pregnant. So within all of those unplanned pregnancies, or the time when women are pregnant and don't know that they're pregnant, people will be drinking with the current culture as it is, and it's a really difficult message to then hear that you may have harmed your baby unintentionally. So we need to be really, really mindful of how difficult a space this is. The one that's really clear is, if you know you're trying to get pregnant, then don't drink. That's the easiest bit of this. But for all of those women who have drunk while they were in early stages of pregnancy without realizing it, or who have issues with addiction and are struggling to give up, this is really difficult, and we need to be really sensitive about how we give this message. Most babies will not have been harmed, but we can't say how many will have been. We can't say what the likelihood is because our understanding of prevalence is so low. So really difficult area. Really important as well, just to be aware of that sense within pregnancy that somehow your body stops being your own, and that everyone can tell you what to do, and people come and touch your stomach in a supermarket in a way that they would never dream of doing normally. So again, a heightened sense of sensitivity to patronizing messages, I guess. So we need to be incredibly skilled in how we deliver this, and I think some of the really important things that we can do is make sure that there is a general awareness, particularly at school age and older, that alcohol can be harmful to a baby during pregnancy, so that information is known before the potential for pregnancy, and not just after. Next one. Okay, so that's the end of the slides that I've got, and we'll move on next. Happy to pick up any questions afterwards if there are any, but I guess the key message is just to go back over them, is that it's really difficult to give definitive answers in terms of prevalence, in terms of how many people this affects, but what we do know is that it affects far more people than have been diagnosed, and that the earlier people know about it, the better the chances of getting some help and some support to improve quality of life. Thank you.
Thanks, Helen. And we'll hand over to Maria Catterick now. Have we got Maria on the? I'm hoping she's here.
Hi, Jason. Can you hear me?
Yeah, brilliant. Just tell me when you want me to change slide, Maria, and I'll move on to the next one.
No worries. Oh, it's been wonderful hearing the presentation so far, and hopefully we're going to take it into the lived experiences of FASD. We've got myself just looking at the broader, what are we seeing as a service of FASD Network UK. We're going to have Charlotte come in and explain her journey as a parent, and the wonderful Alice finishing off our section, talking about what it's like to live with it. It's a lifelong, permanent condition, and she's going to share a little bit about that experience and where she thinks we need to be at. Could you move the slide, please? Wonderful. So who are we? We established in 2011. My background is social work and learning disabilities, but I've been a foster carer 20 plus years, and I've parented 10 kids myself. Found there was this big black hole when I tried to find services, set up a coffee morning, and all day, every day, we are connecting with more than 4,000 families. So if you want to think about the, was it something like 276 diagnosed in the UK that was mentioned before, it shows you that we haven't got the mechanism to establish who's out there. We were talking about it yesterday, and there's probably only about 250 registered with us from the Humber and North Yorkshire areas. So we know it's under-recognised in those areas, largely because it's been underdiagnosed in those areas. We have an online platform that we share with others, and there's about 4,000 families on there. So it's a really broad living case study of what really is going on in the UK across different regions. Majority of our work is based in the Northeast and Yorkshire and Humber regions. We've focused on these areas, and it's been a journey of discovery, because we connect not just with families but with practitioners. And so if we were asking families, what are you saying are the challenges? What's going on? Nearly always the results come back as it's diagnosis. How do we manage supporting our children with FASD? How do we get the support services we need? And it feels like, as a service, we're the only dedicated FASD service in this whole regions. It feels like we're just putting our finger into a hole and trying to plug it as best we can, but nothing is commissioned. And so we're trying to find every which way we can to be creative, to find pathways and ways forward for family. But interestingly enough, when we talk to practitioners, and about half of our inquiries every month are from practitioners, and they're coming out with the same concerns. So I guess the bonus of that is we're all on the same page, whether we happen to be a family or a practitioner. We know what needs to be done. It just needs to be done. In terms of individuals with FASD, we'll often hear a deficit model, all the things that they're going to struggle with. And believe me, this is a very complex presentation for children and young people with FASD. It is a very hard life they're living, and it's very hard for families. But we forget to talk about all the talents and gifts and incredible abilities that they're going to share in our communities and our lives, despite having this complex disability. So please make sure that if we ever communicate stories about FASD, that we also talk about the great stuff as well. Do you want to move on to the next slide, please? So what do we do? There's not a lot we can do without the finances, but what we have learned that will create success. So this really does, it's a simple diagram, but it does create success. We do have to think about those outside areas of prevention and diagnosis and intervention and support. We have to address those as systems, as commissioned systems. And then what do we need to do to create success for that individual and that family? In terms of families, the majority of our families are foster, adoptive, kinship and residential. We definitely have birth parents, but it seems that majority are care experienced. Some of the research is saying over 70 to 80% are care experienced individuals, whether that, whatever stage of their journey. And in our service, we're seeing 85% plus, but we think that that's biased because we have a looked after child medical, annual medical for every child who's care experienced. And so it might be getting picked up easier that way rather than in the general population where they might see some symptoms and say, oh, well, let's call that autism or ADHD and send you down those parallel pathways. So we do see that there's, it's very hard to get a diagnosis. There's no front door system. You have a pathway for autism, a pathway for ADHD, and a zero pathway for FASD. And so we definitely need to be addressing that. So we're seeing inconsistent awareness, quite late diagnosis, if at all. We definitely have people hitting adulthood with no access to a diagnosis. It absolutely does make a difference. It transforms the individual's understanding of themselves and how we tailor any other support service to meet their needs. It is complex, and there's lots of risks and lots of additional dysregulation to manage. But we do see that if we get the right support right, that family unit is really rather stable. But it's taking lots of advocacy on the part of the family. They're not just caring for their child, they're having to advocate hard with services. So it's quite the journey for sure. We look at school. School can work really well if it's the right school with the right child in the right position with the right support. We're seeing a move, the government came out with DBV and SEND delivering best value, and we're seeing a downturn in what's working really well for our children because they're trying to mainstream them more or, have their needs met within their local school at the end of the street. And sometimes it's not about the great skills of the teacher, it's about the context of the size of the school or the sizes of classes of children. So it's sometimes tricky. About 2/3 of our children are struggling to come out with a decent education, but those in the right tailored support are thriving, staying in school and doing really well. But we do need to get school up to speed on FASD. Our friend is not the behaviour policy in school. So the more that they know and understand, the better it goes. And then the final thing we think about is community. our young people have a place to shine. They have skills and talents, and they sometimes struggle with maintaining friendships. Social sort of communication skills can hamper that a bit. But we try all sorts of things, and we're finding all sorts of talents, top level musicians, artists, athletes. They need to find their place, and majority of the time they find the place in general SEND style groups that have adaptations to enable success. Unfortunately, some of those activities are ring fenced, learning disability and autism only, which bar some of our young people. But that is their ways that they can shine. So we can't just work with the family in isolation. We have to work with them within the context of school community services, get loads of calls from safeguarding, lots of calls from justice systems. So the more that awareness is out there, the more that we work together harmoniously as systems and services, the better the outcomes we can have. We look for a positive lives, positive support. And the key support families come back to time and time again is connect us up to other families with FASD. That is where they feel that they fit, they get the best information and understanding, and feel heard and understood. And those feeling most empowered are the ones who are usually raising their voices to push for change. It is the hidden disability amongst neurodivergent conditions, and it's time for it to be addressed. We are thankful nice quality standards came out. 2 years ago, it said that there needs to be diagnostic pathways, support and management plans coming out. We're waiting for that to still happen, but we hear a lot more intention to get things right. And that's a really good, positive place to be. So that's us in a nutshell as a service, but I want to bring in Charlotte now to share her personal story. Are you there, Charlotte? Can you take yourself off mute, Charlotte?
I'm not sure whether she joined on the presenter link, but if she can potentially put a hand up, we could make her a presenter.
Right. Because she said she got the link from you yesterday. I know that Alice is there, and she said she's here. Charlotte's there.
Right. Let's just, if we can. Go. Right. I think she should be able to. Yeah, presenter now. I'll turn on the microphone, right?
I spoke to Alice just before the session, and she said it wasn't allowing her to put a camera on the links that you sent out yesterday.
You can hear me.
Yes.
Oh, hello. Hi, sorry.
Oh, there you are. Yeah.
Technical. Hi. So my name's Charlotte. I'm a birth mum, and I like to champion for FASD. I'm a mum of 5, and I've got a beautiful little girl called Bonnie, who was diagnosed with FASD at birth. So I feel quite lucky compared to the majority, and with what I've learned on this journey. So I personally fell victim to alcohol 2 years before Bonnie was born, and I was just accessing the recovery services for alcohol, and I fell pregnant, which wasn't ideal, wasn't perfect, was one of the worst times in my life. Nobody wants to be in that position and be growing a little person inside of them. I sort of went from super mum, tandem feeding my 2 boys 13 months apart, to being this wreck, growing a little person and not knowing what damage I was doing. And I was very lucky that I'd accessed the services here in West Yorkshire, and at 15 weeks I was taken into detox in a professional unit and given that opportunity to detox safely, because I had tried previously, even though I was under alcohol recovery services. I didn't want to be drinking, and I had a seizure and I broke my nose. I had 2 seizures just because the right amount of alcohol wasn't in my system to keep me stable. So it was a scary time, but I was detoxed. I will have 7 years abstinence 1st of June, and I've got a beautiful little girl. She was diagnosed at birth. She has the facial features. Here in Halifax, they asked me if they could study Bonnie's case. I was very open and honest about the alcohol consumption. I had weekly scans, and I wanted them to have that information on record because I didn't actually realise how dangerous alcohol is. And Bonnie has had multiple operations. So she was born with a full cleft palate. She was born with the dimple at the base of her spine, which is the start of spinal bifida. And I think if they hadn't got me in and got me detox when they did, things could have been a lot worse. She has a raised diaphragm, but luckily it doesn't interfere with anything. She was born with a congenital heart condition. Her heart beats as if it's still in the womb. She has no muscle in one eyelid, so every 4 years she has to have an operation on this. Multiple things. She wears little hearing aids, she needs glasses, but if you met her as a person, she never fails to surprise me. And I think the point I'm trying to make is that early diagnosis, when you have all these operations and other things going on, means that all the support and everybody could preempt. In school, she got her EHCP straight away. We got the blue badge so that we could get to all these regional hospital appointments sort of all over, and we could park up. We could park up with the other children, get in safely. She doesn't gain weight. Very well, she's had her tonsils removed now, and she has gained weight, but she's still on a medical milk, which she's been on since birth. She was NG tube fed until she was 13, 14 months old, because that was tip and go. She was going to have the peg feed put in, but she actually started grabbing the syringe and drinking from it like an open cup. And I said, please let me try. I know she can do this. I know she can do it. And we went on to free flow cups. And she is full pelt 24 hours a day. She does have to have melatonin on a night, otherwise none of us get any sleep. But I think the other part of it for me is the stigma. So that early diagnosis 100% has meant that we as a family could concentrate on what Bonnie really needed, which was the medical side, those big operations, the palate repair, the things where when you're in recovery, like I was and still am, you're feeling shameful, you're feeling embarrassed, all these multiple different things. You've got to change your mindset. Who do you hang around with? How do you feel on a Friday night, on a Saturday night? You've got to tell yourself, you've got to train your mind to think a different way and try and be positive, and helping people. So me doing things like this gives me a lot of self-respect and makes me feel like I'm making a difference and it happened for a reason, and I can maybe help other people in that situation. Peer support is really important. And I think when it's professionals approaching ladies that for obvious reasons don't want to speak about it, if there could be ladies like myself in those rooms as peer support, lived experience, that can say, just you're not alone and you can get through this, that's a massive help as well. The only negative thing I came across personally was going up to my little girl in Skaboo. I was on the ground floor of a hospital. I was still trying to pump off milk and take these little syringes up. And I could overhear conversations of nurses in a demeaning manner. And at that time, I didn't even know what a cleft palate was. So there was all these conditions, and the way that I could overhear people speaking about me was upsetting. It just added to the shame that I already felt. And when you're trying to keep going, nothing was going to stop me from being with her. But that's my sort of personality and my drive. And I don't think every lady would have that. And when we've suffered with addiction issues, no matter the substance, it's a massive trigger for relapse, which is what I think professionals need to be aware of. It's got to be approached in the right way, and those little conversations being overheard could unintentionally cause that lady to leave and think, well, they think that of me anyway, I'm not going to bother, sort of thing. That's the only negative thing I really came across, but definitely early diagnosis, so that support's there, is all I can say, really.
Thanks, Charlotte,
Okay.
for sharing your story. Really powerful stuff. Lots of things that we
Thank
can
you.
feed back there as well into some of our services, and really appreciate that. Have we got Alice on the call? I think you're.
Hiya, can you hear me?
Yeah. Hi, Alice.
Hello. Sorry, I don't know what's going on with my camera.
Oh, you're all right.
So I am an adult and I am 30 and I do live every day with FASD. So my story is I was diagnosed at birth. I was born heavy on alcohol and I was put onto methadone. And then with that, I was in hospital for sort of 6 weeks. I have read a little bit into it. So I know that I was sort of put on that, and then I was in care for 2 years, and then from being 2 up till even now, I was brought up by my grandparents, and we never really sort of understood what FASD is. We never understood how it would affect me. I only sort of recently now do I understand I am the way that I am because of everything that I'm learning and how it ties into this condition. So as an adult, I work in finance. I do work part-time, and then with that, when I'm not working, I am advocating for FASD. And it's definitely sort of helped in sort of understanding it so that work can put in things into place for me. So I struggle with concentration. I struggle with I can't sit and watch films. It's really difficult for me. I can't sit and take loads of information in because sometimes I try to be like a sponge and I can't. So like, and things like adapting to change, we know what happens in businesses, it happens everywhere we go. So when a change is to happen, I'm usually the first one to be made aware of it. If an email goes out, an ops manager will come down to me and explain it to me. I'll make sure that I fully understand exactly what's going on so that I'm not ever misinformed or I'm not open to any surprises, so to speak. But yeah, and then sort of on the growing up side of it as well, I was put into SEN nursery. From a young age, I had loads of I really struggle with my immune system. So I really struggle sort of with being poorly all the time, and I struggled with my maths a lot. And it was a lot of meetings with school and college to kind of get me over that, to get me to where I needed to be. And a lot of that was in primary school. But we never got the support. I never got an EHCP. Those are unheard of until I started advocating. I never had like a teacher's assistant who sat next to me in school. I never had any of that support. I was just kind of, as bad, as awful as it sounds, I was just kind of thrown into the big wide world really at a young age, and just kind of, you like the others, off you go. But because we were never educated in it the way that we are now, I never had that support, and I'm so grateful to have come out of the other side where I'm able to work and I'm able to, sort of live a more functioning life. Sadly, it's not the same for every individual with FASD. So sort of when I'm coming into these meetings and things and I hear all these stories, I think I really had it quite easy in that sense, but I know it's not easy for everyone else. But I definitely look back and I do think if I had maybe an EHG in place and I had the support that a lot of our individuals are getting, I may have thrived a lot more. I would have probably achieved a lot more as well. I also think as well, sort of having, when we talk about FASD, we do talk a lot of a negative side, but there's a very positive side to having FASD and how it affects us. So I'm quite a creative person. I was talking about this to Maria last night, the other night, but I'm quite creative. So when I look at like advocating, I don't just kind of sit there and go, oh yeah, well I'll come into these meetings and I'll talk to you guys and I'll go to all the other meetings and things. It's about getting it out there. So my brain works at 250 miles an hour. So when I get these ideas, I've got notepads on me all the time. I'm always thinking, you know, and and the way I explain things as well, sort of makes it quite creative. And you know, I drive. I'm quite ambitious. I'm quite career driven. You know, and a lot of that has been sort of put into me from my grandparents. But my grandparents, after the conversation when we were looking at all my doctor's notes, said they never wanted to believe that I was sick, because a lot of it they didn't know what to do. They were handed this baby in a neonatal unit and said, right, she's got, well, it was FAS. Off you go. There was no sort of support in place for my grandparents to be able to bring up a child with this complex condition. Anything could have happened. I could have been blind, mute, I could have been in a wheelchair, and thankfully, you know, I'm not in that position. But I think with the support and the help from the NHS, I do strongly believe that I think growing up, it could have been a lot different than what it is now. And I think that's it.
Thanks, Alice. I really appreciate that. Another very powerful presentation there. Charlotte and Alice, thank you for your time and attending today and feeding back your experiences. I'm going to just stop sharing. As I said, we'll share the slide deck after this. The webinar's finished, and then you can obviously access the evaluation. It's very brief, just a few questions on there. I'm just going to stop sharing just to see if we've got any questions. Oh, we've got a hand up. Lisa, do you want to jump in? Are we able to unmute Katie?
Give it a go.
I'll just see what we've got in the chat. Just while we're looking, a massive thank you for our speakers today. Really appreciate you giving up your time. The whole point of today was to raise awareness of, you know, the alcohol in pregnancy and FASD. We do have a sort of steering groups across our ICB, Humber and North Yorkshire, that's looking at this and trying to get, you know, pathways and support and things like that in place. So today is about raising awareness of that and you know, people understand it a bit more and understand what's out there in terms of the support and things. Let's have a look at some of the comments that we've got.
I've put the questions in the Q&A that people have raised during the meeting.
All right, sorry, yeah. Not very good with technology, sorry. Let's have a look. I'm not sure. So the first one is just around North East Lincolnshire. What services are available for diagnosis of FASD, please? Maria, I'm going to say, is this one? I think one of the issues we have at the moment is, you know, the pathways are not there, are they, Maria? I think that, and that's one thing we're trying to change. We're trying to put systems in place so, you know, people can get diagnosis and get that support much earlier. That's what's lacking in the system at the minute, and there is work ongoing to try and sort that out. I think, does that probably summarise, Maria, what position we're in as Humber and North Yorkshire?
Yeah, I think in the pathway discussions, there's a lot of people with a lot of skills, a lot of ability, a lot of passion to get it right. I just think the green light isn't fully there yet. But those meetings are open to people who do want to work on the pathway. So if that's something you're passionate about, get involved. You'll meet other people from North East Links who should be able to have those discussions with you as well.
I've just noticed in the chat, Yvonne's just said she works in the alcohol service in North and North East Lincolnshire, and happy to meet with anyone if they'd like to look at pathways and how we can support. So I think this is a great opportunity for people to connect actually and see if we can start looking at that, and then maybe sharing that best practice across the system to see if we can replicate.
Brilliant. And we've got a note of email addresses, haven't we, Katie? So we will be in touch with people as well and give you that opportunity to be part of that work.
Jason, I'm just wondering, there's a Communities of Practice meeting running by the NHS on the 27th of November, and I think that's also an opportunity for anybody interested to get involved.
Yeah, fantastic. We could share the details of that. We've got everybody's email address, haven't we, kids? So we'll possibly send that invite out to people. And as Maria said, do come along. I think that's the first one, isn't it, Maria, this community of practice. Lots of other areas, because other areas are much further than we are, and you know they have pathways and things. So we'll hear from lots of different parts of the country and the region who'll chat through their, you know, where they are on their journey. But yeah, do get involved. The more people that we get involved, you know, that's how we get the situation sorted out and the pathways and services in place. The next question was about what about male alcohol intake during before conceiving. I seem to remember that when we was putting the slide deck together, I came across some information around male alcohol intake, and I mean, again, Maria and others might be able to support me with this one, but I think, you know, there is a call for males to reduce their alcohol intake as well throughout pregnancy, because it can have an impact on the intake of the mum. And I think that, you know, the advice is to try and, you know, advocate for males reducing their alcohol or stopping drinking throughout pregnancy as well, because that can have an impact. I don't know if you've got anything to add to that, Maria.
Yeah, I think at the current time, science is if the mother has to have drank to create the condition FASD, we are seeing more and more research coming out saying that it's a contributory factor, it exacerbates the risks, and we're definitely seeing if mum and dad have both been drinkers, that's an increased effect. But science isn't quite with us, but it's almost there.
Thanks, Maria. Alice?
Yeah, just on the back of the question around males, I know that at the moment in Canada they are looking at researching the effects of males and see if it can be transferred through sperm. So hopefully, sort of in the next coming months, we should get some more information on that.
Brilliant, thanks, Alice. I can't go down any further, Katie, on the questions. For some reason, it's not scrolling down.
Let me have a look. So we had another question saying, do you think the lack of diagnosis is due to stigma? Would the parent have to admit they drank high levels of alcohol during pregnancy? And we know that that's an issue across the board. So yeah, just a question out there. Maybe Maria, what do you think? Do you think there's a lot of stigma around it?
There can be. We definitely have to learn how to ask the questions carefully, and often we talk about a life story approach if we're going back to parents, rather than saying, did you drink alcohol in pregnancy? And they might say the honest answer of no, I didn't, because they're counting it from pregnancy recognition. Actually, if we do life story, what was life like before you were pregnant? Was this a planned pregnancy? How far along were you when you realized you were pregnant? That takes stigma down. I spend a lot of time talking to women who are pregnant and have exposed their baby. And we often say, you know, around 40% of pregnancies are unplanned and alcohol exposed. Actually, it's a big majority of people who are alcohol exposed pregnancies. So the more that we take that down, the better. But I think the biggest lack of diagnosis is there is no formal diagnostic pathway. We are not asking the questions anyway during pregnancy. We are getting better, and the LMNS is doing brilliantly about doing questionnaires and surveys when they're meeting pregnant women. It's getting better, but historically it wasn't there. And if there's no diagnostic pathway when we're seeing neurodiversity, if we see traits of autism, we're just going to send them down the autism pathway instead. We're sending them down the wrong pathways because there isn't the right front door. I think we have to weigh up both of those sides.
Yeah, I think that leads on really well to the next question, actually, because somebody said there appears to be a strong crossover of symptoms with neurodivergent conditions such as ASD and ADHD. Is FASD considered when progressing through the diagnostic pathways? It sounds like no.
No, not automatically looked at. They're not looking for differential diagnoses. If they're looking at autism, they're looking at autism and leaving the other things aside. What we tend to see is about around half of children with FASD could have a comorbid ADHD condition. Maybe about 20 to 30% might have autism. We laugh, we call it the condition that's got all of the other conditions, but not quite. So there's a lot of impulsivity, there's a lot of social communication difficulties, a little bit of everything, but not everything necessarily hitting the criteria. It's a random selection of neurodiversity. We know there's over 400 potential impacts from prenatal alcohol exposure, and it's a random selection that you get. So comorbidity or misdiagnosis, I describe it as incomplete diagnosis. We might look at the ADHD and get the ADHD diagnosis, but we've left it incomplete. There's lots of other neurodiverse traits sitting above that we leave if we don't address the FASD.
Brilliant, thank you. There is another question asking if there's any national resources available. I suppose we can direct them to your website, Maria. The FASD Network has got a lot of information available there, isn't there?
Yeah. And it depends what kind of resources. So again, as part of the pathway plans, lots of different groups are looking at prevention and maternity, and they've got their own literature that they've already looked at. There's a campaign called Dry Mester that came out of the Salford area that a lot have gone to. Some have used the Blackpool Super Babies prevention. So it depends on what kind of resources you're looking for. You might look in different places for different things, but we can always navigate you to something.
We can try and group together as much information as possible and follow up email to people as well, just to get the ball rolling on that one. We've got a few more questions asking sort of specific support in certain areas. So again, we can pop that sort of contacts in the email that we're aware of and just try and link people in. But we will say just get in contact with us in the ICB. We can certainly try and link people together wherever possible. Just see if there's any more questions in the chat. Can't see any more burning questions. They're a bit more specific, which we can come back to directly. Yeah, any more questions? Feel free to put your hand up and I can take you off mute.
I think while we're waiting, Katie, we'll be sharing the recording what we have the webinar will go out, and then we'll look at the comments, and any, you know, if we've missed anything, we'll be back in touch. We'll feedback and obviously share that community practice event that's happening as well, and feel free to join into that. Yeah, and a big thank you for our speakers for today. We couldn't have done it without you. You know, I think it's been really interesting and really you know, it's raised a lot of issues around FASD that we need to sort out, that we need to be better at, and hopefully, you know, the work of some of the groups that we've got up and running will solve some of those issues. We've got a hand up.
Yeah, I'll just.
Hi there. I put a question on the group chat about whether or not there is a lower age limit in terms of seeking diagnosis of fetal alcohol syndrome spectrum, because I've got a specific case where there are obviously some signs have been noticed in terms of low growth and some of the things that were mentioned around facial features and jittery arms for a baby, but and obviously they've had looked after medicals and so on, and the general consensus was that that the child isn't old enough to receive a diagnosis, even though, you know, they are showing some visible signs. And I've obviously, from some of the presentation, it was mentioned that there was early diagnosis, and that's been really helpful for some cases.
Do you want me to respond to that?
Please, Maria.
Yeah, certainly we've got children who've got quite a lot of the physical difficulties at birth that have been recognised at birth. Even that birth diagnosis is incomplete, because what we need to know is how are they affected, and we know the most vulnerable organ is the brain, and we have to wait till they're a little bit older to be able to test how is their brain working, how do they function on daily life. So that it's almost like a two-stage diagnosis. If you get diagnosed at birth, great, you've got your diagnosis. Second way that you need to address it is to do cognitive assessments, adaptive functioning assessments, and usually for most conditions, neurodiverse conditions, it's around age 6 when they can really participate well. So if they don't have those early medical issues, most are being looked at initially around age 6, 7, so that we can do that full range of assessments. And the typical assessments, cognitive assessments, adaptive functioning assessments from a psychologist, speech and language and OT. But if we bear in mind, early intervention is always best. You don't need a diagnosis to start your speech and language work. You don't need an early diagnosis to start with OT input, or to start making accommodations for how a child is functioning within the school environment. So early intervention with or without diagnosis is still advisable. Diagnosis is most likely to be around 6+ though.
Thank you. Thanks very much for that.
Thank you. I don't know if there's any more questions.
Just a lot of love for Charlotte and Alice in there. Thank you so much for sharing your stories. I think really what's come to light today as well, this is really kind of just the start of the conversation across the system, and we've got so much more to do, but I think it's a really great area that we're sort of delving into now, and obviously a lot of interest, and we want to make it better. So
I think there's just one last question, Katie. If it was suspected a child did have FASD, would the referral be made through the GP? I don't know if that's one you could answer, Maria, before we...
Yeah, so anybody can refer. Typically, what most families are doing, if there's they suspect FASD, go through the GP, ask to be seen by a paediatrician, because it's a medical condition, not a behavioural condition. It's not through CAMHS and SIPs. It is through the paediatrician, and you ask to be seen by someone who is familiar with FASD. Challenge we have is a paediatrician can't sign off on the diagnosis. They can do their medical unless they've had a psych assessment. So sometimes we need to find a way to navigate both, maybe an educational psychologist or get access to a clinical psychologist. But yeah, typically GP to paediatrician is the way to go.
Brilliant. Thanks, Maria. So I'm conscious of time, a few more minutes left. We will share the recording and the slide deck with everyone. As I said, there is an evaluation QR code and a link if you get time, literally just a few minutes. If there is any questions that you've got after we're closed today, pop them in the evaluation and we'll hopefully get a response back to you. I'd like to finish on a massive thank you to the speakers for giving their time today, for attending and talking through their experiences and the resources available. And then I'm gonna end it. Thanks everyone.
Thank you.
Thank you.